So I think many of you know Anne Lenoy. We worked together for a long time, and she's been a great influence in my practice and the way I practice, and helping me develop in this area. So Anne and I actually put this talk together last year. So what I'm talking about here is the mechanism of Alzheimer's and the genetics. So the question is this just an accident, or is it actually representing a change in the state of the normal brain function? Is this a normal physiological process that's actually just been triggered, and now we've got an excessive reaction going on? So cellular suicide, we know, is a normal process. It happens in every cell around the body. But in the brain, we know that cell death is a slightly different mechanism and then occurs in other cells. And the way it does this, it develops into a prionic loop, which I'll talk about a little bit later, which is one of the bases of how Alzheimer's disease develops and how it self-perpetuates. Once we develop that amyloid beta protein, it actually just feeds back into the loop and causes more and more to be produced. So the normal mechanism in neurons, we've got dependence receptors. So I've never used one of these. Okay, there we go. These dependence receptors, which stick out of the cell membranes of these neurons. Now you can see these dependence receptors are very dependent on ligands, which are neurotrophic ligands, which if we have the ligand, it binds and the signal goes through and we have cell migration and cell proliferation. However, if there's an absence or even just a very low amount of that ligand, the ligand doesn't bind to the receptor, and we get programmed cell death or apoptosis, which is what happens. So the precursor protein in the brain is the amyloid precursor protein. That's actually the dependence receptor, and that's produced by the neuron. So what we know is that, as we've seen in the slide before, is very dependent. That amyloid precursor protein or dependence receptor is very dependent on these neurotrophic ligands, and they can either switch the process on to forming new brain cells or new synapses and connection, the synaptoblastic pathway, or if the trophic factors aren't there, we actually go onto the synaptoclastic pathway, which is where we break down these synapses. And we can see here that in all chronic illnesses, we have this balance in osteoporosis, cancers, and in Alzheimer's. And what we're obviously wanting here is not to be on the synaptoclastic side of that balance. We want to be on the synaptoblastic side of the balance. So how do we activate that synaptoblastic pathway? As I spoke about, we've got these neurotrophic ligands which bind. And when we're on the synaptoblastic side of the pathway, which we call the anti-Alzheimer's disease pathway, when they bind, what happens is on those dependent receptors, we then get these, the amyloid precursor protein, it's snipped in with this enzyme protease, and we want it to be snipped into two. They talk about the duo or the quartet. And when we get just the two individual peptides formed, that will be synaptoblastic. That will send that message through for cell proliferation and neurogenesis. So we want it to be on this side of that balance. So some of the neurotrophic ligands: netrin-1, estrogen, vitamin D, testosterone, insulin, thyroid hormone, SIRT1, which is a longevity molecule, and actually is upregulated with resveratrol. So good to be drinking our red wine for that. Sleep-related molecules and stress-related molecules. But if our dependence receptors lack any of those ligands, or they're in a very low concentration, we can see we're now on the pro-Alzheimer's disease pathway. And we now snip into 4 little peptides, and one of them you'll see is the amyloid beta protein. So, and that is the side which then sends the message through for cell death. And the other word we use is that synaptoclastic mechanism. So as long as those neurotrophic ligands, if they're low or even absent, then we know we're going to switch across into that synaptoclastic pathway. And we saw in the pathway before that the production of that amyloid beta actually happens when we snip into 4 peptides. And as long as we have that going, we're producing amyloid beta, and the amyloid precursor protein then binds, it sort of grabs onto that amyloid beta protein and causes that whole pathway to go again, and we break down more and form more of this amyloid beta protein. The amyloid precursor protein binds to it again, and this whole process happens again. And that's what we call this. The amyloid beta protein is responsible for that prionic loop, where we don't need genetic material for it to make more of each other. It's a self-perpetuating loop. We produce more, it binds to the receptor, it breaks it down, we produce more, and it just goes on. And that's one of the mechanisms of mad cow's disease. The plasticity balance, as I said, is very important in all chronic diseases. We can see that in osteoporosis, we really want to be more osteoblastic bone formation rather than osteoclastic, where the bone resorption. In cancers, obviously, we would want the breakdown of the cells, and we don't want any new cells forming. That's the side we want to be uppermost. And then in Alzheimer's, we want the synaptoblastic. We want these synapses and new neurons to continue. Don't want to break down those connections. So as we age, the inputs obviously decrease, the synaptic growth and maintenance grows more scarce. So there are less ligands to bind to those amyloid precursor proteins, and we result in naturally downsizing. So as we get older, that will happen, and it's the recent memories that are the first to go, usually, and then the older memories later. So currently, as Yael was talking about, there are 36 different types. There are more, actually, that they're talking about now, but we look at mainly at 36 different molecular mechanisms, which are the contributors to tipping us either into the synaptoclastic or blastic side of that pathway. And we know that they talk about a threshold. We don't have to plug every single one of that 36 holes. It might be 15, it might be 10 for one person. It just depends. Every person is different. And it obviously depends on what type we've decided of Alzheimer's that they have. So it's about the threshold and that tipping threshold, which we're aiming for. And as Yael said, this is the reason that no one single drug is going to ever treat or slow down or Alzheimer's. We need to address enough of those to tip our balance into the synaptoblastic path. There are many steps involved in looking at those mechanisms, which I'm not going to go into now, because it's about 3 pages worth of mechanisms, but we can test for a lot of them in the lab. Obviously, we're not going to test all the 36, but we do as much as we can, and we don't have, unfortunately, access to all the testing that we need in this country. We talked about the roof with 36 holes, so we're not going to do that again. And we've spoken about that. The one hole is never going to tip the balance, never going to be enough to alter the threshold. So instead of that single pill, we're looking for all these other mechanisms, and we're trying to work out which are the factors which most play a role in these patients, and what are we going to do for them. The main areas, as Yael showed us in that lovely slide, we look at nutrition, exercise, hormonal optimization, sleep optimization, stress reduction, synapse supporting substances, and specific herbs. And the aim of the treatment obviously is to push us into the balance of synapse destruction to synapse preservation and removing all the contributing factors. And there are the three main sort of metabolic processes we look at are inflammation, and then shortage of these trophic factors, and toxic compounds. We've evolved to develop the APOE3 and 2 genes. We were all APOE4, E4 homozygotes 7 million years ago. But when we had a much shorter lifespan and having that inflammatory, high inflammatory process wasn't so terrible for us, because we didn't have the diet we have today. We didn't have the sugar. People moved around a lot, and also they didn't live as long. But as we've lived longer in that constant high risk with the inflammatory process, we obviously now facing cardiovascular disease, dementias, and things that they weren't facing in those days. So APOE3 only, we evolved to, that gene developed 220,000 years ago, and the APOE2 80,000 years ago. So how does APOE4 actually sort of impact impact our risks and the development of Alzheimer's disease? So we need to look at what is APOE4, what does the gene do? It increases how often that amyloid precursor protein sends that downsizing message through to cut it into the 4 peptides and get that synaptoclastic process going. It also decreases the clearance of amyloid beta protein from the brain. And the other thing, which is very interesting, it codes for a protein which can then enter into the nucleus and efficiently bind to DNA in cells. And it specifically binds to 1,700 genes. So out of 20,000 possible genes, if it can bind to that, and that's one of the reasons why we see it creates such an incredible inflammatory process and reaction in the body. So we need to understand the mechanism behind Alzheimer's to give us clues as to how we're going to possibly try and prevent the disease and halt the process and try and reverse it. So step 1 is really to identify the types. Dale Bredesen talks about the 3 types, actually the 5, but the ones, these 3 are related to the APOE4 gene particularly. And the APOE gene. So type 1, he's called inflammatory and hot, type 2, atrophic and cold, and type 3, toxic and vile. Type 4 is related to sleep apnea and also vascular disease. So hypertension, cardiovascular disease will play a role in type 4. And then type 5 is due to traumatic brain injuries and people who develop memory issues with traumatic brain injuries. So the genetic risks of Alzheimer's disease, if you do carry the APOE4, so no copies, so even if you have no copies, you still have a 9% chance of developing Alzheimer's. If you have 1 copy, the risk is 30%, and 2 copies, it's 50 to 90%. I mean, it's a big, initially he wrote about 50%, but now they're talking closer to up to 90% if you homozygote for E4. So the type 1 or inflammatory, you're more likely to have 1 or 2 copies of that APOE4 gene, and so it tends to run in the families. They clinically present with the loss of the ability to store new information, and so it's the early memory, form new memories. If you're homozygote for E4, you could develop this in the late 40s to 50s. If you're an E4-3 or E4-2 combination, late 50s to 60s, and the E3, still you can develop in 60s to 70s. Now, Dale Bredesen has created a protocol called the Recode Protocol, and so this inflammatory type has got the quickest response to that protocol. Then type 2 is the atrophic type. This also occurs in people with APOE4 1 or 2 copies, but usually occurs later than the inflammatory type, type 1. The clinical picture is quite similar, and it responds more slowly than type 1 to his protocol.
Sorry, are these different types of Alzheimer's?
These are different types of Alzheimer's, yes.
Type 1 would be the...
Type 1 would be the inflammatory type. Type 2 would be the atrophic, which is all your lacking of your vitamin D, your hormones.
As you see it,
Yeah.
Opposed to any test that might be done.
Yeah, so, you know, we talk about, it's symptomatic as you see it, and looking at, so it would be looking at the gene. So you always look at a couple of things. You'll look at the gene. They obviously come in with some memory issues. You'll do your MOCA, you'll do various other testing as well, and you put it all together to get the diagnosis. Is that answering your question? So because we look at different, when we're looking at this, we look at is the subjective cognitive impairment, where often patients will come in and they'll say, you know, I'm a bit worried about my memory. And there isn't a test. You do the test, they'll score 30 out of 30, and there's nothing really going on. But if we had to look, they might have an APOE4 might be hormones, it might be thyroid. There are lots of issues that we have to look at. So that's actually the time that we really have to grab onto these patients and do something. The next part would be the mild cognitive impairment, which is where a family member might have noticed as well as there's usually one area that they're struggling in, but they'll still score on their mini mental. They'll score between 20 and 26 on their mini mental, and then for it to be Alzheimer's, they need to be less than 19 on the MoCA, and then we look at so particularly if we're looking at the Recode Protocol, that would be we'd stratify according to and specify which type they had, because that would then it'll inform you as to which treatments you would use on their protocols. Because we can't just do the same thing for everybody, because everybody's got a different reason for theirs. So that's why it's important to decide which one they're in. And then it's the combination of type 1 and 2, which they call type 1.5, which is the glycotoxic. And this, so they've often got features of 1 and 2, then often diabetes, and they call it the sweet type. And then type 3 is the toxic, and often APOE3 carriers that have this, but it could also occur in the APOE4, and it doesn't typically run in families. If a relative did have it and they had APOE3, it was late onset Alzheimer's and potentially into their 80s that they developed it. Symptoms can develop in your late 40s or up to 60s, and often a big stress event might precipitate this. And they will clinically present with cognitive difficulties with numbers, speech, or organizing. They talk about people who suddenly sitting with a bill and they can't work out the bill, or they can't work out the tip, and those are areas where with the numbers that go before the memory. And they need a different protocol because these are toxins, these are molds, these are lots of other things, and mercury. We need other protocols to treat the type 3. So in summary, really, the three types of Alzheimer's that we've talked about now, they really correspond to these three processes that influence the amyloid precursor protein. So we're looking very much at the inflammation, loss of trophic factors, support, and exposure to toxic metals. And they will send those downsizing messages, and we'll have cell death, and that will accelerate that pathway. The discovery of these three types has been quite crucial, and crucial implications for the way we treat the person and for the therapeutics. So we need to know which of the cognitive factors are present which are the factors present in their cognitive decline, so that we can address each one and address it appropriately. So this is an amazing book if you want to have any information on this process, and that's it.